MDMA, methylene dioxymethamphetamine, is an N-methyl analogue of its predecessor MDA, methylene dioxyamphetamine. It's interesting to note the transition from its first synthesis back in 1912 by German chemists looking to produce substances to stop abdominal bleeding, to its potential for being utilised as behavioural and toxicological weapon, secretly tested by the US Army in the 1950s and then finally hitting the streets in the 70s. Once known only as a designer drug, now being explored in depth for its properties in psychotherapy, aptly titled MDMA-assisted psychotherapy in the treatment of alcoholism, PTSD, and anxiety disorders, to name a few. Production of MDMA is considerably more challenging than that of methamphetamine, as this multi-stage process requires a fully equipped laboratory. The reactions are far beyond that of which my current understandings of chemistry lie, but classically the precursor for all approaches is the plant oil saffrole. Saffrole is extracted from the root bark or fruit of the sassafras plant. Ecstasy pills often have varying quantities of diluents and adulterants. Otherwise, the pills are usually cut with other things, leaving you with less MDMA and more of the things you weren't asking for, such as benzylpiperazine, methamphetamine, and 2CB, ketamine, caffeine, random research chemicals, and a bit of everything else. The nasty and sometimes lethal side effects are usually results of additives found within ecstasy pills. The problem with pills is that the user is oblivious to their composition. MDMA can also come in crystal and powdered forms. Both can be snorted, taken orally, or sublingually. MDMA inhibits the action of the serotonin reuptake transporter, preventing the reuptake, packaging, and recycling of serotonin. Evidence suggests that MDMA acts to reverse the actions of these SERT transporters, therefore resulting in the efflux, in other words, pumping out of serotonin into the synaptic cleft. In addition to acting on SERT, MDMA also exerts a similar effect to a lower extent on the norepinephrine and dopamine reuptake transporters. To recap, serotonin, otherwise known as 5-hydroxytryptamine, is a key regulator of a number of biological functions, including sleep, heart rate, appetite, pain, and the most widely known, mood regulation. We associate the drug with feelings of euphoria, intense love, and other subjective effects such as disinhibition, enhanced sociability, stimulation, and an altered perception to sound and touch. That wired stimulant feeling, often described by users, is a result of the excessive dopamine accumulation at the synaptic cleft. The effects of MDMA can be felt after 20 to 90 minutes, with its peak being felt between 1 to 2 hours. Dosing usually starts at 70 milligrams, but some users may weigh up to 150 milligrams and more. Days following MDMA usage will leave users depressed and anxious due to the lack of readily available serotonin. According to McGregor et al., the empathic or better described entactogenic effects of MDMA are a result of the release of oxytocin. You've probably heard this is a substance that is released when a mother bonds with her baby, or when you embrace a partner following an intimate moment. Oxytocin is a hormone that is thought to facilitate trust building and bonding. The negative side effects include tachycardia and hypertension. However, experienced users may enjoy this feeling, whilst novice users may become concerned with their heart racing. Jaw clenching and teeth grinding, dehydration, increased body temperature, erectile dysfunction, and failure to achieve orgasm are also some side effects that may be experienced. After effects are effects that are felt the days following the usage of MDMA and can include brain zaps, anxiety, depression, suicidal ideation, cognitive memory deficits, and sleeping difficulties. Beyond this, there are some quite serious side effects that can occur, including seizures, neurotoxicity, cardiotoxicity, and its high abuse potential. Furthermore, MDMA is contraindicated with many other drugs that are often seen within the same scene where MDMA would be found, for example PCP, GHB, cocaine, and alcohol. These can all result in serotonin syndrome, which is caused by an excessive synaptic concentration of serotonin. Serotonin syndrome is usually caused by combining serotonergic agents such as monoamine oxidase inhibitors or selective serotonin reuptake inhibitors. But since many over-the-counter drugs also have non-specific affinities for serotonin receptors, it can also occur from things like antihistamines. Serotonin syndrome exists as a continuum spectrum where mild versions of serotonin syndrome often occur, where hypothermia, confusion, and hyperkinesia develop. Reversal of the mild versions of serotonin syndrome can be achieved through resting in a cooler environment. However, people on MDMA often don't recognize these symptoms, continuing to dance in clubs with already elevated temperatures, furthering their dehydration and hypothermia, which can be fatal. However, if one is a conscientious MDMA user and attempts to maintain fluids, due to the altered hypothalamic control, fluid regulation circulation is dysfunctional, meaning excessive fluid intake can occur, causing hyponatremia, which can also be fatal. So while some MDMA users may have died from hypothermia, others will have died from hyponatremia. Other acute causes of MDMA-induced death include cardiac failure, renal or hepatic failure, rhabdomyolysis, and disseminated intravascular coagulation.